So with our understanding of metabolism in place, we can finish the pharmacokinetic story by talking about elimination. So this segment is where we're going to talk about clearance and half-life and elimination kinetics, and some of that helps us better understand the utility because these ideas directly influence the dosing decisions of healthcare providers. When we kind of think about drug elimination, oftentimes we think urinary excretion, but drug elimination is really much broader than urination alone. Drugs leave the body through urine, bile, breath, sweat, saliva, breast milk, and other routes. So the practical point is that clinical conditions can slow or alter the elimination. Dehydration, renal failure, liver disease, those can all change how a drug remains in the system. So when elimination is impaired, dose or dosing intervals might need to change to avoid accumulation. So this figure here illustrates the enterohepatic circulation, which is one of the body's primary mechanisms to recycle or eliminate certain drugs. Well, after a drug is absorbed from the intestine, it travels to the portal vein and to the liver. We know this as the first pass effect. In the liver, the drug may be conjugated, perhaps with glucuronidase acid, for instance, and this makes the drug more water soluble. And from there, the conjugated drug can then enter the bile and be delivered back into the intestine. Again, kind of circular thinking here. Well, in the intestine, bacterial enzymes may deconjugate the drug, allowing part of it to be reabsorbed and returned to the liver through the portal circulation. Well, all this to say, alternatively, drug metabolites can be eliminated in the feces or cleared through the kidney and the urine. But the key point is that elimination is not always a one-way path. And sometimes we think of it as only this mechanism. But some drugs can cycle between the liver and the intestine, and they prolong their presence in the body, and they prolong the effect that they may have. See, a lactating mom may have some drugs that make its way into the breast milk, so the baby gets a fair amount of that drug too. And clinical scenarios like dehydration, where not a lot of fluid is going through the kidney, renal failure, a diabetic who has decrease in renal function, right? Certain drugs may need to be adjusted because the interval of intake may need to change due to an accumulation of the drug or an inability to rid the body or break down or excrete the drug from concentration. Liver failure in chronic alcoholics, prime example, where drugs are metabolized by the liver via enzymatic inactivation. But if we have liver failure, maybe this isn't working as well, and usually the liver metabolites, they're trying to prepare the drug for elimination via the kidney. So there might be some challenges given some of the physiologic process or mechanisms might be damaged, broken, or other pathologic disease might be causing some challenges. So of course, this slide is talking about renal drug elimination, but before I go too far, I want to touch on one more point here. With that first pass effect, the liver working to break down the drug, have you ever taken a drug that required conscious consideration for other foods that you were consuming? Maybe, for instance, a physician says, hey, when you take this drug, let's say it's Adderall, you can't take grapefruit with this drug. Which kind of seems interesting because the grapefruit increases the effect that the drug is going to have on the body. And that's because grapefruit competes at the liver, so less drug is being metabolized by the liver because those liver enzymes are competing to break down the grapefruit, and therefore less is breaking down the drug, so more drug is making its way into the system. Pretty interesting how some of this can go about. So let's turn our attention to renal drug elimination. Well, the kidney is one of the major organs of drug elimination, and the nephron helps to explain how that happens. So drugs can be filtered into urine, secreted into the tubule, and in some cases resorbed back into the body. And that means the kidney function is a major determinant of how quickly certain drugs are going to be removed. So when the renal function declines, medications that depend on renal elimination, they may remain in the system longer than expected. So this again highlights the importance of the kidney functioning properly. So this figure here, the one in purple, shows the proximal tubule of the nephron. Now, the kidney can eliminate the drug from the body via the urine, and we may need to consider if there's a concern that the drug could be resorbed back into the body and stay in the system. As you can see in the figure, metformin, which is a diabetes drug, is eliminated via the urine. Now, cimetidine is a drug which may be great for regulating stomach acid, but the issue is that it would block the transporter for metformin moving from the blood to the urine. So way more metformin is going to stay in the blood because it's not making its way into the urine. So this is where we have polypharmacy needing to be accounted for. A great question is, this isn't working, what other medications are you taking? Or did you recently start taking a new medication? Cidofovir, listed on the screen. This is an antiviral. Other drugs like pobenicid, these can be prescribed for gonorrhea, but they would block the pathways for cidofovir. So it's critically important for physicians to understand which drugs may interact with the elimination pathways of other drugs, because in the instance of polypharmacy that has competing events, one drug may get far more interaction or far more response than another. That also opens the door for side effects. So we need to be conscientious of polypharmacy, recent medications, or a change in medication, all of these considerations pertaining to whether or not a medication is going to have its intended effect within a therapeutic range. Now this slide depicts zero order kinetics, and that means the body removes a fixed amount of drug per unit of time, and it's regardless of how much is present. So alcohol is a classic example. The line is linear because the removal rate is limited by the system's capacity, not by the concentration in the usual way. So clinically this matters because taking more of a zero order substance does not mean it will clear proportionally faster like we see in some other medications. The system can be overwhelmed. So substances like alcohol, or listed on the screen as ethanol, provide zero order kinetics, which is a linear removal rate of the drug. So in this case, the rate of elimination is fixed. Metabolism's not based on concentration or serum concentration, but rather alcohol metabolizes at the same rate with higher doses. Now, enzymes for metabolism are different in everyone, which explains the wide variation of individuals who can drink differing amounts with the same end result of alcohol intoxication. So, normally, for other drugs, a high concentration has a high rate of elimination, which is referred to as first order kinetics, and we'll see that on the next slide. So we need to keep in mind all of these considerations of how things are being impacted. Now, there are only 3 clinically important drugs exclusive to zero order elimination, and that's ethanol, phenytoin, and aspirin. And the elimination pathways, are relatively linear in that way. So we say that there's a straight line decline in terms of the drug elimination per unit of time. So here we see an example of first order kinetics, and the figure jumps right off the page. This is no longer a linear rate, but rather the rate of elimination is proportional to concentration. So when we have a higher concentration, the body eliminates more drug per unit time. Similarly, as concentration falls, the elimination slows accordingly. Well, many drugs follow the first order kinetics, and this is why the time course of drug disappearance often looks curved rather than perfectly linear. And here in this figure, we see a much faster rate of removal for drugs with a higher concentration. So this means the higher the concentration, the faster the drug will be eliminated. And in the case of first order kinetics, this explains why a low dose and a high dose of a drug still metabolize to zero at relatively the same time point. Now, on the screen, we see a couple of things here. The vast majority of drugs operate with first order kinetics. The rate of elimination is proportional to the plasma concentration. So as plasma concentration declines, we have a different or a change in the rate of removal. In purple, the exclamation mark, right? We look and see some drugs that follow first order kinetics at low doses. That's what we're observing here. And some may follow zero order kinetics, like we saw on the previous slide, at higher doses. So why would they differ between the two? First order at low concentration and zero order at higher concentration. Well, this is because the elimination pathways can sometimes become saturated at higher doses. So this all has to do with oversaturation of enzymes necessary for metabolism. So think about it like this. The body is maximally working, so the rate of elimination is at maximum. The rate is constant. That would be zero order kinetics. All of the enzymes are operating at the same exact time, so everything's working in conjunction. But then as we start to decrease the concentration, we now return to a first order kinetics, because now not all of the enzymes are maximally involved, and now we transition back to first order kinetics. When all the enzymes were involved and we were at 100% use, then we were at a linear rate of removal. So drug clearance tells us about how effectively the body can remove a drug or medication from circulation. So it reflects the contribution of organs such as the liver, the kidney, and it's influenced by a couple things. So those would be age, organ function, and route of administration. Now, a young and healthy adult may clear a drug much more efficiently than an older adult with reduced organ function, for instance. So the same dose does not always create the same time course in every patient. And this is what we're seeing in that figure, where the half-life increases with age, the clearance decreases with age. So this up to about 40 years of age, right, might be pretty much the same for most of our individuals with some statistical variation. But as the person gets older, the enzymes slow down, the clearance declines, and this causes the half-life of a drug to increase. And of course, that means the drug's going to remain in the body a lot longer at age 80 compared to age 40. Now, all of this being said, we understand there's bioavailability is based on how much is eliminated by first pass kinetics, and then how much is absorbed in the body. This has to also a factor to do with clearance. So reduced clearance often means a lower maintenance or dosing requirement. So these are factors the physician is always taking into account in this consideration. Now this figure is a very good visual reminder that route changes both onset and reliability of the medication. So administration with intramuscular injection, we see a very large rise in the concentration of penicillin in the serum, but a very quick fall. Falls relatively quickly because the intramuscular injection may absorb relatively quickly. Now, subcutaneous delivery is a lot slower, and oral dosing is the least direct because it depends on an absorption through the GI tract before we have systemic availability that's achieved, right? Going through the liver, et cetera, and making its way into the circulation. So route choice is part of the pharmacokinetic planning. In this case, we're looking at this figure where PO, standing for oral, is really the worst in terms of getting a lot into the blood. However, when a physician's prescribing medications to a client, this is maybe the preferred dosing strategy so the client or the person, the patient, can self-administer at home. They don't have to come in for injections every day. They don't have to administer IM or IV at home. So we have to consider or take into account, right, some of the considerations here as to what the best mechanism is versus what is the mechanism that is the most tolerable by the patient or the most reliable that this is going to maintain long term. Now, we've spent a little bit of time talking about clearance, but I think another key component is half-life, and that's the time that's required for the concentration of the drug to fall by 50%. So the amount of drug in the system, there's a time frame for which it will fall by 50%. Now the concept is extremely useful because it helps us predict how long a drug is going to remain active. Also how long it may need to be dosed and how long it may take to clear once discontinued. So when you hear terms like half-life, we're going to think of this as one of the most practical timing tools in pharmacology. So in this diagram, what we see is person takes a first dose. This is red, where the concentration rises up to 4 milligrams per liter and has a half-life of 6 hours. At 6 hours, we get another dose, and this is the first orange line. So in that first redose, we get up to a concentration now of 6. Go another 6 hours, the half-life, it's dropping down. We get another dose, and this brings us up to now 7. So this is an example where we see if we only took the one dose from the very beginning, the half-life of 5 half-lives kind of rule as how long it would take to kind of clear that drug out of the system. So after 5 half-lives, we're looking at the red line, we're near 97% complete clearance of that drug. Now, there are some drugs that have really, really, really long half-lives. Take amiodarone, for instance. Amiodarone has a half-life of nearly 100 days, which means it can take a year and a half until the drug is completely cleared from the body. So in this case, if you understand elimination clearance and you understand half-life, you can start to predict how often a drug should be given, how long it will remain in the body, and why the same regimen may not fit every patient equally well. So in terms of dosage regimens, these are really about maintaining a therapeutic concentration. And that's what we observe with the black line in the figure. That's the therapeutic dose that kind of is our target. And this is maintaining a therapeutic concentration. So the goal is to give enough drug at the right interval to stay above the minimum effective level, but of course without drifting too high to the point where we're getting into a realm of toxicity. So if the interval is too long, the concentration falls and the effect might be lost. If the interval is too short and the dose is too high, the concentration can accumulate too far, too much, and now start to encroach on that toxic level. So dosage regimens, they're an attempt to balance the effectiveness with safety over time. So as we see the black line kind of being the target therapeutic level that we need to maintain for a medication, blue would be taking a drug with more concentration less frequently. So we have a higher dose concentration, and maybe there's a really high therapeutic index, and we're not worried that this high dosage is going to be near a toxic level. But the physician can now say, hey, we can prolong your duration to take this maybe once a day. Whereas orange is a smaller dosing with more frequent dosing intervals. So we should ask ourselves, what's the end game here? If we're giving a patient penicillin for strep throat to prevent rheumatic fever, well, some of the sequelae or conditions which are kind of consequences of the disease or injury might be taken into account. If we give a small dose 4 times a day and give a large dose 2 times a day, both may prevent rheumatic fever, but it may be more practical to have the person, so that they don't forget a dose, to take it in a larger dose 2 times a day. That way, we also have to consider what the lethal dose would be. If giving a dose 2 times a day means we get too close to that lethal dose or toxicity, well, of course, that's not an option, and we clearly have to go with the smaller dose more frequently. So again, we're balancing therapeutic index, toxicity level, and the patient availability to remember to take a dose right once a day, twice a day, 3 times a day, and make it as convenient for the patient and as therapeutically relevant for the patient as well. So as we've discussed, if the important questions that a physician asks when administering a drug, those might be, how often does the patient need to take the drug? How much drug does the patient need to take? And then, of course, we have to first consider half-life, route of administration, right? How much is going to be usable on first pass effect? And then we need to understand how much of the drug stays in the blood versus moves into other tissues, so that we really understand, is there a high or a low volume of distribution? Is any of the drug going to be bound with protein? Are we trying to saturate? Are we competing with other drugs that are binding or using the same enzymes? So all of these considerations have to be considered when we're considering clearance and absorption and bioavailability. So this slide's a good summary of the dosing logic. So a provider has to think about all of these things and consider what might be most realistic for the patient when prescribing medication. You know, how quickly the drug concentration falls in terms of half-life, or questions as to whether once a day or twice a day or more frequent regimen makes sense. In other words, the schedule is not arbitrary, it's tied to both pharmacokinetics and patient behavior. So these are all the things that must be considered as a patient is getting diagnosed and prescribed a medication, in addition to what other medications are you currently on, because if there's an interaction between the two, one might have to have a change in the dosage, maybe higher or lower depending on that competition.